Boa noite, gente, tudo bem? Meu nome é Fábio, sou diretor de eventos do ECUSP. Queria agradecer mais uma vez a presença de todo mundo que está aqui, que está assistindo online. Nosso segundo dia. Ontem a gente falou um pouco da parte teórica de como faz o diagnóstico diferencial e hoje a gente vai falar um pouco dos casos clínicos, que a gente vai ter uma discussão meio interativa sobre os casos clínicos. Então, muito obrigado pela presença. Hélène, thank you very much for the opportunity. For the second day, it's something incredible. Então, gente, eu espero que vocês aproveitem. A Hélène vai falar mais um pouquinho hoje. Então, é isso. Boa palestra para todo mundo.
I will try to don't speak so much as yesterday. Today you will work. We will play, okay, with cases, and we can discuss of all the aspects you want. Okay, just don't hesitate to stop me. I hope you received the description of the clinical cases. No. Just because at the beginning of the slides, we have the differential diagnosis of the systolic murmurs and of the diastolic murmurs. And that's what I propose you. I describe the case and we will try to guess the diagnosis first, okay? And after I will show you the echocardiography and so on, and we will go on up to the diagnosis. And sometimes we are going to try to give a prognosis or to answer to the question that the owner asked us on the case, okay? Thus, if you send the papers to everybody, they will have, I suggest you to have in front of you just the differential. When it's a systolic murmur, you take the table with the systolic murmur differential, and when it's diastolic, the other one, okay? This, as I said yesterday, we are not going to speak about all the things, but just the most frequent diagnosis we have in equine cardiology, and this makes you 95% of the case, okay? No problem. Okay, first case, I don't know if you had the opportunity to read it. It's a mare, half-blood mare, the kind of horse we have a lot in Belgium. I think here also in Brazil. It's a 3 years old, okay? The clinical history is that when she was 6 months old, she went in a clinic, in a very good clinic in Ghent. Ghent, that's the other faculty in Belgium. We have one faculty with French-speaking veterinarians and students, and another one with Dutch-speaking. That's why in a so small country we have 2 veterinary faculties. Okay, and there is a guy doing a lot of cardiology, as Günther Wallon. She was in this clinic, and she had a murmur. But we don't know what was the murmur and if it was evaluated or not. I think it was not evaluated. After this, she had a normal growth. She had a surgery for umbilical hernia at this moment. And the owner started to work with the horse just 3 weeks before presentation at the faculty. Yeah? And when they tried to work with the horse, they remarked that the horse was very exercise intolerant. It was evident. They didn't know it before because she was just at pasture and she just had a normal life, but they didn't see anything. And also they mentioned an edema of the forelegs, okay, because the mare came in a box, in a stable, and presented it. Okay. On physical general examination, she had a tachycardia. She was around 72 beats per minute. She had the bilateral jugular pulse, which was irregular, an irregular rhythm, and some edema just under the sternum. On cardiac examination, the auscultation gave this. Pumpa. We'll do it again. Okay. Pumpa, pumpa, pumpspa, pumpspa. Systolic or diastolic? Systolic, we agree, it's just written after if you have the slides in front of you, okay? And what was evident also that was the earth sounds were audible in a very large area, okay? There was a trill in both sides of the thorax. the heart rate was completely irregular, and thus it was indeed an holosystolic murmur. And based on the whole examination, I can say you that it was a grade 6 out of 6. Okay, it was irradiating widely, audible bilaterally. Okay, and PME as the point of maximal intensity was on the base of the heart on the left. Okay, that was the ECG. Okay, and my first question will be, what is your diagnosis for this ECG? Thus, I suggest you to connect to the same system as yesterday, that you can take on the QR code the connection to the WooClap system, or go to WooClap and put the code cardio24, okay, like yesterday, it was the same. And you don't have to put your name, or you put a name you imagine, there's no problem. Anyway, we will not see the name, no problem. And here I suggest you 4 possibilities. Do you think it's a sinus arrhythmia? It's atrial premature contractions, a 3rd degree atrioventricular blocks, or an atrial fibrillation? What do you think? You can vote. If you are connected, you should see the question. We have 33% connected, but only 2 voted. No. Try anyway, it doesn't cost anything. Just try. We'll see after the statistics. We are not going to see your name on the screen. No idea, we didn't evaluate the differential diagnostic of arrhythmias yesterday. Okay, we can speak a little bit of arrhythmias if you want. Okay, but I think you have a lot of ECG courses here, and normally you should. It's the same as in small animals. Huh? The interpretation of the ECG is the same pathologies as we have. You are hesitating. Okay, let's see what the 4 first person had. You don't really know. Sinus arrhythmia, is it an atrial premature contraction, an atrial fibrillation? We don't know. Do you want a theory on atrial fibrillation, or we do the clinical case only? Do you want some theory, some theoretical information on the atrial fibrillation, maybe? Okay, we can do that right now. Because apparently you don't like it. You are a little bit hesitating. Okay, we can go here. That's concerning the differential diagnosis of arrhythmias. I will not go through all the diaporama, all the slides, but only the main, maybe, to understand this case. Okay, is it okay? It's okay? No. If I change the PowerPoint,
I just have to transmit it from here.
Okay.
Yeah.
You don't have my screen.
There's no problem.
Okay. Each time I change, you have to change.
Yeah.
Okay.
But there's.
Okay. Thus, I'm not going to develop everything, but in most of the case, when we have an arrhythmia, the rhythm of the heart is not regular. You can have different kind of arrhythmias. The first one is you have a basic normal rhythm, and sometimes there is a missing beat, like pumpa, 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 pumpa. Okay, this is one. Or you can have an additional beat, a normal, regular, basic rhythm, and sometimes an additional beat, like pumpa, 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 pumpa. Or the third possibility is a completely irregular rhythm, no basic regular rhythm and something different, like pumpa, 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 pumpa. Pumpa, okay? And the differential could be associated with this, okay? If you have, I will do that very rapidly. If you have a basic rhythm, regular, and sometimes a missing beat, it can be 2nd degree atrioventricular blocks, that you all know, it's very frequent in horse, or sinoatrial blocks that are always physiological, okay? I'm not going to develop everything. Oh, like just something amusing. If you want to, do you know it? You know this video? If you can imagine when the atrium depolarizes, they do like this, okay? The depolarization and contraction of the atrium. And after the depolarization go to the sino-ventricular nodes and the ventricle contracts. Depolarize and contract. Atrium and ventricle. And it makes like, this guy is really going to show you. Atrium. Oh, there is a block, okay, just the atrium contract and it's no depolarization of the ventricle after, just because it's amusing, okay? Well, we are not going to develop everything now. If you have no regular rhythm and sometimes an additional beat, it can be an atrial premature contraction, a ventricular premature contraction, or a third degree atrioventricular block, which is very, very rare, okay? We are not going to develop it right now, because what we have in this particular case, it's a completely irregular block rhythm. Like here, what is your differential? It can be a sinus arrhythmia, which is completely physiologic, okay? It can be an atrial fibrillation or ventricular tachyarrhythmia, this atrial tachycardia or ventricular tachycardia, okay? Well, let's go to we are here with our case. Let's go to atrial fibrillation, okay? It's frequently associated with exercise intolerance. In this case, we have an exercise intolerance. Is it because of the atrial fibrillation or does he have something else in addition? We'll see, okay? Thus, on auscultation, it's completely irregular, okay? And also the intensity of the beats, the sounds can be different from one beat to the other one, okay? And then clinical signs, it can come from completely asymptomatic to very intolerant exercise and showing signs of dyspnea and things like that, okay? And also one clinical sign that can be interesting in a horse that develop atrial fibrillation is the fact that suddenly he is going to show with exercise pulmonary exercise-induced pulmonary hemorrhage. Okay, this is something that a lot of horses show. But if a horse was never presenting this and suddenly he presents hemorrhage epistaxis after exercise, think to auscultate the heart because maybe he developed an atrial fibrillation and is just developing epistaxis because of it. Okay, this can be part of the signs. It's not specific, but it can be. Okay. With atrial fibrillation, we have two kinds of atrial fibrillation. It's isolated, okay, idiopathic, or associated with other heart problems and thus developing secondary, okay? Thus, in our case, is it primary or secondary, okay? The kind of auscultation we'll have is like this one, by instance. The sound is not very good, but you heard that it's completely irregular. Sometimes you have the impression of an atrioventricular block, but in fact, if you heard to the basic rhythm, it's completely irregular. We'll listen it again. Competition. Or this one. Okay, so if we simulate it with this guy, it will be like this. The atrium doesn't contract in an organized way, but they are fibrillating, and sometimes there are depolarization of the ventricle. On the ECG, the QRS complexes will be normal, okay, just appearing irregularly. And we have no P waves before the QRS, thus we have just a fibrillation wave in place of the A waves, okay? Like here, by instance, or here. Frequently, those horses during exercise develop severe tachycardia, and thus it can be dangerous to ride those horses. But this is a detail, okay? Thus, the clinical significance of atrial fibrillation, it's always pathologic, okay? Cannot be physiological, because some arrhythmias in horses, like we saw for the murmur yesterday, some arrhythmias are physiologic and no importance for the horse, okay? But atrial fibrillation is always pathologic. Sometimes it can be paroxysmal. It means that it appears and spontaneously it will disappear. Because if you have a horse with an atrial fibrillation, you see, you auscultate him for the first time, you are sure it was recent, maybe wait a little bit, because maybe it will resolve just without any treatment, okay? The treatment, the sooner we treat and the best it is, and we know that we have approximately 3-4 months to treat the horse. If the problem is isolated, it's not secondary to another cardiac problem, okay? Thus, if you treat the horse within the 3-4 months of apparition, but the problem is often that we don't know when you auscultate the horse that you have the arrhythmia, you don't know exactly since when the horse has the problem, okay? If he presented suddenly an exercise intolerance, the owner is sure that the horse has been auscultated recently, he was not arrhythmic, and suddenly he developed exercise intolerance and an arrhythmia, then for sure it will be associated with a recent atrial fibrillation, okay? The chance of success is good if there is no underlying cardiac disease. Are we going to treat these horses for his atrial fibrillation? We will see. The age of the horse is also important. It's a young horse, it's better, and always look if the horse is not in potassium deficiency. But this is a detail, okay? If you have a good candidate, no underlying cardiac disease, recently occurring, and in a young horse, the rate of success is very good. In the past, it was around 60, 70, and now with more recent techniques, we arrive to 98%, 95% of success. Wonderful. And if you are successful, the horse is returning at a completely normal life. The performance return to normal. But he can have a recurrent problem. The atrial fibrillation can come back, okay? In 15 to 40% of the cases, they have another occurrence of atrial fibrillation. But you can treat again and again, return to normal to normal performance. I don't know, do you have quinidine sulfate here in Brazil to treat it? How do you treat it? Do you have a drug, an antiarrhythmic drug no? That was the drug of choice we had in Europe for many, many years, okay? It works quite well, okay? But just a little bit toxic. Yeah. And the risk was to have a sudden death during treatment. Thus, you announce to the owner, okay, we can treat the horse. If we are successful, the horse will be completely healthy, will return to normal performance, but maybe he will die during the treatment. Then some owner hesitated to do that. Now the problem is that we have no more this molecule, this drug in Europe on the market. And then we had to change, okay? And in the literature, you will find a lot of different anti-arrhythmic drugs. I don't know, these are anti-arrhythmic drugs of human medicine, because I'm pretty sure you can find it on the market here. I don't know if you use it in horse. It works, not very well, but it can give some results, but there are a lot of toxic effects with those drugs, okay? More than with the quinidine sulfate we had. And then now, recently, there is a new method to treat these horses. It's electric cardioversion. To do that, I don't know if you are interested that I show you how it works, okay? It's something we don't do at the faculty, because the faculty just nearby us, which is the Ghent faculty, it's one of their specialty is to do the electric cardioversion, okay? What do you do for that? They just put first a big catheter in the jugular vein, okay, a big one, and in this catheter they can put longer catheter that they put inside of the catheter. They push it in the jugular vein. It goes to the right atrium, right ventricle. You continue to push, and you will arrive in the pulmonary artery. Just right ventricle and pulmonary artery. Just pushing the catheter. And the first thing they do is that they position all the catheters using the echocardiography to control the positioning of the catheter. You can also use the pressure at the end of the catheter to know where you are. Okay, when you arrive in the ventricle, you will have a typical trace. Thus, they put one catheter in the left pulmonary artery, one in the right atrium. Okay, and one is just in case they have a cardiac arrest. It's a pacing catheter. Okay, just in case. And they will put an electric shock between the left artery, pulmonary artery catheter and the right atrium catheter, to reorganize the depolarization of the atrium in connection of the ventricle. Okay. Thus, they do put the catheter on the standing horse. They control the position of the catheter. After this is to know where are the catheter. You see the catheter is here in the right atrium, right ventricle. Okay, and after you push it, controlling the pressure into the right ventricle and therefore on the pulmonary artery. You see on the echocardiography, you can see the catheter throughout the right atrium and right ventricle. Okay, and in the pulmonary artery here, the catheter is there. Okay. After that, they do a general anesthesia. Okay, they control again that the catheters are all in the good place. Okay, and after they will do an electric shock, and they will do several electric shock at increasing amplitude up to the moment they will obtain the defibrillation. And I will show you the movie because it's amusing, and you will understand why it is not done on standing horses. Okay, as they wait. Günther is there. Okay. This is the shock. Okay, it's better to do that on the general anesthesia. Okay, you see, my friend Günther is just looking at the ECG. It doesn't mind with the horse, jumping during the depolarization. Okay, and thus they control the ECG. This one, you have the shock here. You see a big amplitude on the recording, but still an atrial fibrillation after, and this one here, atrial fibrillation, the shock, and oh, wonderful, defibrillation is obtained. Okay, this is the electric cardioversion. With this system, the rate of success is very, very high. Thus, we are happy because we can send our horses with atrial fibrillation to this clinic to do the cardioversion. I will not develop the rest. Okay. Yeah, that's it. I will change to the other one. Then, on our horse, come back here. I let you. Okay. Does my horse has an atrial fibrillation? Is it primary or is it secondary to another cardiac problem? We come back to this.
Sim, é melhor assim demais.
This will continue. Okay or not? No?
Just, I have to.
It's difficult when I go from one to the other one.
Voltando no slide dela.
Ela vai ficar mudando de slide de novo. Yeah, vê se vai agora. Foi?
Maybe I will stay on this one. No, we had already. Better. Okay. Then at this point, the owner asks, are those cardiac abnormalities responsible for the exercise intolerance of my horse? Because I remember the owner came because the horse was exercise intolerant. And what is the prognosis for this horse, for life, for sport, okay? And also, what is your differential concerning the murmur? Thus, you have the table with the differential diagnosis of the systolic murmurs, okay? Come back to our case. What do you think on this one? Do you think it could be an ejection murmur, a mitral insufficiency, tricuspid insufficiency, or a VSD? Okay. Do you want the history of the horse again to decide and description of the murmur? The history was very exercise intolerant, an history of murmur when he was 4 years old, and this is the characteristic of the murmur. It's holosystolic, a grade 6, irradiating widely, bilaterally. You still have the question in your telephone? Yeah, okay. This, I let you doing your votes. What do you think for this horse? What will be your diagnosis? Mm-hmm. You have sufficient. On the slides I send you, you have also the description of the cases. But of course, we have the question, and at the same time, it's difficult. So let's see where we are. Oops. Yeah. I have 5 votes. You are prudent, huh? Try something. Anyway, doesn't cost anything, okay? It's just to stimulate discussion after. And person at distance can vote also. Huh? They know, okay? No problem. Yeah, vote! Come on, participate. No? No additional vote? What happened? Only here we have more than 6 people, huh? Yeah. 7. Come on. 8. Yeah. It's increase. At 20, I will show the answer. Okay. If you don't want, let's see. Difficult to say. I have a predominance on mitral insufficiency, ejection murmur. Well, ejection murmur, I wouldn't select it because just the grade is important. Grade 6 out of 6, and it's holosystolic. These are 2 criteria to decide, okay, cannot be a physiological murmur. Okay, this I would exclude it. Tricuspid insufficiency, the point of maximal intensity should be on the right and not on the left. Then I would exclude it also. Ventricular septal defect also, normally the maximum point of maximum intensity is on the right, but maybe we are a little bit wrong. And something in the history of this horse was suggestive is the fact that at 6 months old, he has a murmur already. This, why not already the ventricular septal defect? Could be. Otherwise, for all the criteria, mitral insufficiency is the one that corresponds the most closely. And something makes me thinking to the mitral insufficiency is the fact that he has atrial fibrillation. It's typical. Okay. Let's see. Go to the echocardiography. Maybe for the baby it will be. Yeah, I can do that, but for the baby we will not be awaking her. No, it's okay, but after. Like, sorry, it's too much, no? Yeah. Okay. Okay. Any suggestion of this movie? What do you think? Is it normal or not? Do you see something abnormal? Remember, it's the long axis view with the left atrium, left ventricle, interventricular septal, septum, right atrium, and right ventricle. We don't see a defect, but sometimes it's very small and we don't see it. Okay. Any suggestion? Any comments? Yeah, Fabio, you have one.
Yeah.
What?
The form of the left atrium.
Absolutely. It's rounded.
Round,
yeah, it's more rounded normally. Absolutely. Motion of the septum. You see that it's contract too much. Okay. the horse can be very stressed, but also it's very highly suggestive of a volume overload of the left ventricle. See, the left ventricle seems to be like it has difficulties in contracting, and all the motion are exaggerated. Okay. Also, if you look at the mitral valve here, it seems to be a little bit thickened. Okay, it's too thick. Okay? And the motion of the valve, it's abnormally increased. Okay, that only with the echocardiography, basic echocardiographic view, you already see abnormalities. Okay, here this is the Doppler. Okay, from the right side, and you see that there is a very, very huge mitral insufficiency. It was the good diagnosis. That explains the large left atrium, okay? And there is a left atrium overload, and there is a left ventricular overload also, okay? You see on the insufficiency, it's all those colors mixed and going back to all of the depth of the left atrium, okay? This is the short axis view. What do you find? Normal, abnormal? No comments? You should be anesthetized at the end of the cases. This is the first one. Attention, we have 9 cases. If you want to go up to the end. No, but you see, again, it's contraction exaggerated. It's a short axis view of the left ventricle. It's completely exaggerated. You see that it contracts irregularly, but we knew that already with the stethoscope, okay? We saw it on the ECG. You see the ECG there with the atrial fibrillation, okay? The tachycardia, arrhythmia, and completely exaggerated contraction. There's volume overload. The volume overload is also seen here in the time motion view. What it's evident here is the fact that you see that contraction of the septum is exaggerated already. There's the thickening of the septum during systole, it's exaggerated. During diastole, it's rather thin because the ventricle is dilated. Okay, we will measure the internal diameter of the ventricle after, okay, to see if it is dilated, but subjectively it seems to be dilated. And something also very interesting, you remember this, the fact that the septum is pushed in the direction of the right ventricle during relaxation, during diastole. It's because the pressure in the ventricle is increased. It's like a balloon that will be with too much pressure, okay? Then during diastole, normally the septum stay on a line, okay? And here, during diastole, it's pushed in the direction of the right atrium, okay? There's many signs of volume overload again. This is the pulmonary artery, okay? What we see on this view is the fact that this artery seems to be a little bit asymmetric, a little bit increased in diameter. You will measure it after, I will show you. Okay. This is the, okay, here, again, the left atrium seen from the other side, from the left side, okay. What you see when we stop during diastole, okay, this is not a movie, but a picture. You see that we are in diastole, okay. You see that the mitral valve is pushed in the direction of the atrium. There's always, again, a sign of very severe volume overload. And this is the, oh, okay, so it's an image also. This is the mitral insufficiency seen from the left side this time. Oops, sorry. Here. Oh, I don't know what happens. Oh, okay. Well, when we do an echo, we do measurements, as I explained yesterday, as we did in the horse this afternoon, okay? And then on each case, we do the measurements. We do that 3 times, 5 times. We do the mean of the measurements. We have a measurement, and we compare it to the reference value for a horse of the same breed and of the same size, okay? And what you see here in this horse, all the measurements with a red, catheter, are out of the limits. It means here the interventricular septum in diastole and in systole is during systole the thickness is increased, and during diastole it's decreased as compared to normal value. The left ventricular internal diameter is very, very wide, 14 centimeters. For a horse of this body weight, the maximum will be 12 centimeters. Thus, it's dilated. We saw it, subjectively, but now we can measure it. Okay. The left ventricular free wall during systole was increased, and the diameter of the pulmonary artery, the diameter was increased and was higher, nearly the same as the aortic diameter, which is clearly a sign of pulmonary hypertension, because as I explained this afternoon, normally the pulmonary artery is smaller than the aortic, the aorta. Okay, the relationship between left atrium and aorta was increased. Okay, the fractional shortening, which is a proportion of contraction of the ventricle during systole, has increased, but we saw it, just looking at the images and at the movies. Okay, and the ratio between pulmonary artery and aorta was increased. Okay, there's a lot of measurements that were out of the reference value. The summary of this case: we have a young horse with a very severe mitral insufficiency. Okay, we have the leaflets of the mitral valve seems to be modified, seems to be thickened. There is an increase in the diameter of the left atrium, of the left ventricle, of the pulmonary artery. Okay, we have clear signs of congestive heart failure in this case, and we have tachycardia and atrial fibrillation. Okay, well, thus we have to answer to the honor question. Do you think that this is responsible for the exercise intolerance of the horse, and what is the prognosis? Okay. What would you say in this case? First, are the cardiac abnormalities, are they the responsible for the exercise intolerance? Or do I have to do other exams to explain why this horse is exercise intolerant? Yes, maybe, or no? Easy. You have only 3 possibilities. What would you say? Let's try. Maybe you don't remember everything yesterday. I'm sure you don't remember, but what is your feeling? Okay. Let's try. I will wait a little bit because I'm pretty sure. Why do I have so little number of votes on this person? 7. We'll try to have more than 8. Try. No? Yeah? People are really prudent, huh? Oh, they don't have a phone, maybe. Let's see. Okay, most of you say yes, and I agree. Maybe it's always a good answer. Never be too strict when you answer to the owner anyway, okay? But I would be pretty sure that in this case, any doubts, okay? I think it's associated, okay? And then if the owner asks for a vital and sport prognosis, let's see for the sport. What is your prognosis for this horse? Is it good for the sport and for vital prognosis? You will say, poor sport prognosis and poor vital prognosis, or a poor sport prognosis but a good vital prognosis, or a poor sport prognosis but uncertain vital prognosis. What would you say? What would you suggest to the owner? Of course, if you could have some time and take the slides we had yesterday, and you can go to the consensus paper and see if you have the criteria to say good prognosis or not a good prognosis. I will show it to you after, of course, after your work. We are at 5. If you lose person during the session, fine, I will have 1 vote. 7. Difficult. It's always difficult. Really, really difficult to give a prognosis on cardiac cases anyway. Okay, most of you say a poor prognosis, and we all agree, I think, that indeed this horse has already exercise intolerance. We are pretty sure it's associated with the cardiac problems, okay? And vital prognosis, you never know. Sometimes we are going to say, oh, prognosis is very poor, you should euthanize the horse directly, but maybe the owner will chose to wait and finally to don't euthanize, and 2 years after he will come back to you, hey, it's not yet dead, okay? Or maybe 2 weeks after you will say, oh yeah, you were right, he died alone, okay? Well, then very prudent, okay? Let's see what our consensus say. You have the table and you have in red all the criteria that meet this case. Okay? You see that most of the criteria are clearly on the right. The right is guarded to poor prognosis. I think we can be pretty sure that the prognosis is not good. And in fact, in this order, what do they suggest? Okay, is to re-examine the horse at least annually. I would say more regularly on this one. Okay, and don't let this horse be ridden by somebody. It's dangerous to ride this horse because the diameter of the left ventricle and the right atrium, it's already dilated. Thus, we gave a guarded prognosis, but the owner didn't want to euthanize the horse directly. He didn't want to treat the horse. He was 3 years old, you know. You remember treatment of congestive heart failure are purely symptomatic, and when you start the treatment, it's for the life. It's at 3 years old. If you had to treat this horse for life, it will cost a lot. Okay, thus they decided to don't treat, but just to give him a chance to live a little bit more. And they came back to us 1 month later, saying that the horse suddenly, they let the horse at pasture. They didn't ride the horse anymore, and he presented a syncope. And at this moment, they were ready to euthanize. Okay, if we treat the horse with furosemide and digoxin, most likely we will prolong the life of the horse, but we will not resolve the problem of mitral insufficiency. Okay, I would say this is a case pretty easy. You remember each time we spoke about the pathology, we say they are very, very light cases, easy to say that it's not important. We have, on the opposite, very severe cases, and this is an example of a very severe cases. At 3 years old, can you imagine? Already with a very huge mitral insufficiency. Remember, it is not associated with age, then it can occur. Okay. Okay, case 2. This one was easy. A French saddle mare, okay, 7 years old, okay, used in military 3-day events. Okay, I don't know how you call that. Okay, on 1 meter on 3-day events, it's already a good level. Okay. And the owner want to go to higher level of competition, okay? And there was a cardiac murmur detected as part of pre-purchase examination, a classical one, okay? You want to buy the horse, you examine the horse, you auscultate, and oh, he has a murmur. What I am going to do with this murmur? But this horse is not presenting any clinical signs, no exercise intolerance, okay? The buyer tested the horse was very good, okay? Absolutely no clinical signs. On clinical examination, it was normal. The auscultation was this. Systolic or diastolic? Systolic again. Indeed, holosystolic murmur. The grade again was 6 out of 6. It was rough. You can hear it on the recording. It was audible bilaterally, like the first one. And the point of maximal intensity here was on the right cardiac apex. Okay. What's your opinion on this horse? Do you buy it or not? Do you let it buy or not? Okay. And what is your diagnosis? It will be always the same. The first question, what is your proposition for the diagnosis? Okay. Do you want the slides again with the characteristic of the murmur, maybe? Yes, we have it here. Okay. History, 3-day events, horse performing well. Let you a few minutes. Does the table is the differential diagnosis of systolic murmur? Let's see how many of you. Oh, we have less and less votes. I am a little bit afraid of the following. Try. No, it's increasing. Let's see. Okay. Ejection, the most prominent votes are for the ventricular septal defect. Indeed, it could be a possibility, okay, to be put in balance with the tricuspid insufficiency, because the point of maximal intensity is on the right, okay. A tricuspid insufficiency can give all the characteristics of this murmur also, okay. And an ejection murmur, I wouldn't take it just because it's a grade 6 out of 6, and the point of maximum intensity is not in the aortic region, but in the tricuspid area. Okay, let's see. This is the echo. Okay. Do you see something abnormal? It seems relatively normal. Okay. Maybe the horse is a little bit stressed and the contraction seems to be a little bit exaggerated. But do we see a ventricular septal defect here? In this image? No. Okay. Let's see now the aortic road. Okay, we move just a little bit the beam. Okay. This is the aorta here, right atrium, right ventricle, left atrium here. Okay. Do you see something? Not really. Yeah. Well, the only one thing I would say, maybe the motion of the tricuspid valve is a little bit abnormal. Okay, but it's not evident. Now, if we go to a closer view, you see that there's this a very, very small hole here at the entry of the aorta, and you see this abnormal motion of the tricuspid valve pushed upwards during systole. Okay, but it's very, very small, in fact. Okay, as if we stop the image, we can measure it, and it's 2.1 centimeter. Okay, we can compare to the diameter of the aorta. Okay, it's less than 1/3 of the diameter of the aorta. This is the Doppler. We put the Doppler in the area, and it's more easy to detect the septal defect. It's a case of septal defect. Okay, it's easier to see it with the Doppler because you see the turbulent flow going through the septum during systole. Right now. Okay, you see it? Turbulent flow. You can also put the continuous Doppler on it, and you see that there is a turbulent flow here. You remember this afternoon we had a flow which was laminar, and I said you have an envelope. You have a lot of red blood cells flowing in the same direction at the same speed at the same time. And then we have a signal, and inside of the signal we have no Doppler signal. In this case, it's different. You see that there is a turbulent flow, there are red blood cells going at different speed at the same moment. And it gives a signal like this one, okay? It's coming from the entry of the aorta to the right ventricle, this left to right ventricle, that it's coming the direction of my beam, it's positive, okay? And I can measure the speed of this shunt. And the speed is higher than 5 meters per second. Remember it, because it will be important for the prognosis, okay? This is the same horse on short axis view. Nothing special to say, okay? It's normal. And this is the M motion view of the same horse. Normal, this one. Completely different as the one we saw just before, okay? This is the pulmonary flow. Do you see something normal? Yes, no? Try. There's just a very, very small insufficiency here during diastole. No. No. You see the small insufficiency? This is pretty physiological. Okay, this is not important, but because you do the Doppler, you see some very little things. This is from the left side of the horse. We have the aorta here, the left ventricle here. You see the ejection during systole. No. But during diastole, again, you have a very, very, very small aortic insufficiency. Okay? But very small. We do measurements of all the structure, and for this horse, OLS within normal value. The summary in this horse, that we have this mare is performing well, absolutely no clinical signs. She has a small ventricular septal defect, 2 centimeters. The maximal speed of the shunt is higher than 4.5 meters per second. It's more than 5. And there is no dilation of the ventricle, of the atrium. There is no mitral regurgitation. No very important pathology associated. There is a very mild aortic and pulmonary insufficiency associated, but that's it. Okay, and as you can imagine, my next question is, what's your advice for purchasing? Okay? You can say to the owner, to the future buyer, okay, buy it, no problem, no restriction. You can say, okay, I will give a favorable advice, but I would like to do an ECG during exercise before. Or you can say, wait for 1 year, we do a control echocardiography and let's see what happens. Okay? Or you say, oh, it's very difficult to give an advice, or you give an unfavorable advice. There is no one good answer. Huh? This is a discussion here. Can I put the lights or? Yeah, the baby is not there? Okay, attention. Just to wake up. Doo-doo. What do you say to the owner? 5, 6, I want a little bit more. 6. Okay. Remember, it's always difficult to give an advice. And in such a case, I will put on my report only what I see, description of all what we had on clinical examination, on the echocardiography, but I will not put an advice written. I discuss with the buyer, I discuss with the person who will sell the horse, but that's it. And your advice was, okay, rater favorable, suggesting an ECG during the exercise. This is a good idea. In fact, if you have a look on what the consensus say, this is a slide of yesterday, okay? In such a case, they will be very positive, okay? They say, okay, the size of the septal defect is it's really small, okay? And the maximal shunt velocity is higher than 4.5 centimeters, huh? Okay? I had no increase in cardiac chambers. I have no aortic regurgitation or mitral regurgitation significant. It was not significant what we saw. Okay, I have no pulmonary hypertension, no signs of cardiac heart failure. No, for this group, the prognosis is good, but they suggest to do an ECG during exercise, just to be sure. Okay, then we did an ECG during the exercise on this mare and gave a favorable advice for pushes. I agree with the people who selected this suggestion. Okay. And now we suggested to do a control echocardiography yearly, but after you don't know if they are going to do it or no. And the price of the horse they have to discuss between the seller and the buyer. Okay, it's not your problem. You just give an advice and that's it. Okay. Question, comments? No? Okay. Case 3. Still alive? Continue? Okay. Okay. Then this is thoroughbred Arabian gelding. 15 years old. Yeah, it's an endurance horse. Yes, it's 1 star, I think, 80 kilometers. I think it's 1 star at the FAE level. Good performance, performed quite well. But you know, those horses had to have vet gates visits before the race, during the race, and during those auscultations, the vets auscultated a murmur, okay, at the last race. And then the owner wants to know if he can continue to use this horse on endurance competition. Physical examination, of course, is normal. He's performing on 80 kilometers. Can you imagine? It's a lot. Okay? And we have this kind of murmur. Systolic or diastolic? When you have a murmur like this, okay, so roaring, and in a old horse, always think to something we are going to see just after this. Indeed, holodiastolic, okay, decrescendo, okay, it's vibrating, roaring, okay. The grade is 4 out of 6, okay, and the point of maximal intensity is over the aortic area. Thus, my first question would be, what is your diagnosis? This is the other table, differential diagnosis of the diastolic murmurs. You get it? You have your opinion because the question is coming. Remember, you have it. Huh? We want to see the table before to vote. It's okay. Ready? Easy. Okay, you can vote. The differential was rapid ventricular filling, presystolic, aortic insufficiency, or pulmonary insufficiency. Differential is easier with diastolic murmurs, but the difficulty is to hear is diastolic. Well, let's see what we voted. Aortic insufficiency, well, for most of you. Presystolic and rapid ventricular filling, remember that those were physiological. The physiological murmur always have a low grade. Here it was a 5 out of 6. This is already impossible. Okay. And the point of maximal intensity of those murmur on diastole are in front of the ventricle, more at the apex of the heart. Here we are on the aortic area. And the murmur is irradiating broadly, which is not possible with the physiological murmur. Okay. And pulmonary insufficiency, remember, it's difficult to hear with the stethoscope. With the so prominent murmur, it's not possible that it could be. You can have a pulmonary insufficiency associated, but it's not this pulmonary insufficiency that will be responsible of this murmur. Thus, let's see what the echo say. Attention. Up. Blackout. Okay. Do you see something special on this one? Maybe the ventricle is a little bit contracting too much. Maybe, yeah. And this is often the case with the aortic insufficiency, because each time the ventricle relaxes, some blood that was supposed to be ejected in the aorta come back in the ventricle. Thus the first chamber they will dilate in those cases is the left ventricle. Okay. This is the short axis view, pretty normal in this horse. Okay. The M-time motion view also normal. Okay. This is the tricuspid flow here. Normal, abnormal? What do you think? Normal, completely normal. Red, okay. No turbulent flow at closure of the valve, no problem. Okay. Then, because, no, that's okay. Mitral flow, it's a diastolic murmur. Those mitral insufficiency is not likely, but you can confirm that the mitral flow is completely normal, okay? And this is the aortic flow. You see there that the diagnosis of aortic insufficiency is confirmed, okay? You see the insufficiency is here along the septum, okay? But it's moderate to severe, maybe, but it's localized in the ventricle. It doesn't take all the depth of the ventricle, finally, okay? If you measure the speed of the regurgitant flow is pretty high, okay? We do the measurements of all the structure, and the conclusion is that nothing is delayed. Oh, see, yes. The left ventricle is it's at the upper limit, a little bit dilated. The impression we had at the beginning was indeed associated with a small overload of the left ventricle, but it's slight. It's not very severe. Okay. Just in summary, in this course we have I will put the light on. Okay. A 15 years Arabian thoroughbreds, performing well in endurance race. He has a mild pulmonary insufficiency and a moderate to severe aortic insufficiency. We didn't see the pulmonary insufficiency, but I can say he has. And I have a slight left ventricular volume overload. Arterial pulse, we didn't say it. The clinical examination was normal. In those cases, remember, always take the pulse. And it was normal, amplitude was normal. Okay. Then, what's your advice? He can continue to do endurance race or not? And do we have to reduce the distance or to be careful? Don't ride the horse anymore? What will be your opinion? Favorable without a restriction? Favorable, but you suggest to do an ECG during exercise? Do a control echocardiography in 1 year to decide? Very difficult. Or unfavorable. Stop to do endurance with this horse. What would you say? I 6 votings there. Okay. Nobody is favorable without any restriction. It's a good idea because indeed this we have slight dilatation of the left ventricle and the insufficiency is moderate to severe. And then the advice of the consensus was do an ECG during exercise on those horses and do a regular control echocardiography to evaluate the evolution. Okay. But very difficult to give an advice. It's always a good answer. No problem with that. But let's see on the table with the suggestion of the consensus. You see that most of our criteria are for an excellent to fair diagnosis. Okay. But they also say that attention, do an exercise during ECG to be sure that the horse is not developing exercise-induced arrhythmia that could be dangerous for the rider. Okay, it's the only one thing. And do a control echocardiography twice a year. Again, it depends the owner. Are they going to do it or not? This is not your problem, but you suggest it. Okay? And this kind of horse are able to continue to do competition for a very long time with a very slow evolution. But it's the control echocardiography that will help you in giving a more accurate prognosis. Okay? But for me, this horse can continue to do performance. And most likely, the horse will continue that for many years. I don't remember on this case, there were no exercise-induced arrhythmia. Okay? We gave a favorable advice. He continued to do the races with regular ECG and echocardiographic control. One more? I have plenty, but maybe too much anyway. Next? Or you want to pause? Yeah.
I just want to ask something. how beats the heartbeat per minute to say something about a case of
The heart rate, yeah, but in most of those cases, the heart rate at rest, you mean during exercise? Okay. At rest, in most of those cases, the heart rate at rest will be normal. It's very rare that if we have already a tachycardia, like in the first case, in most of the cases, they will have other clinical signs associated. It will not be the first one, okay? That's less likely. Now, during exercise, you could have an increase of the heart rate during exercise, but it's very difficult to evaluate. Is it because it's not well trained, or what's the reason of that? It's not specific. Then we don't use it a lot. It's mainly the exercise-induced arrhythmia that are important for this consensus group. In fact, in this group, you have one of the person that was member of this group had an history of in his clients. She had a horse with a severe aortic insufficiency. She suggested to do an ECG during this exercise, and when she was doing the ECG, the horse fell down and died just in front of her. And then, since then, she was very afraid of having this kind of problem with another problem. And I am pretty sure that she pushed, in the direction of, be prudent with such horses. But it's very often we have arrhythmias in those horses. Maybe because of the thickening of the left ventricle, remodeling of the myocardium in such cases, I don't know. Okay. Well, but the heart rate by itself, not very helpful. Okay. Case 4. Okay. It's a mare, thoroughbred mare, 3 years old. Okay, she is doing racing. Okay, no exercise intolerance. It's a good mare, but you see the horse in the context of a pre-purchase examination. Okay, clinical examination, of course, is normal. Okay, and you have this kind of murmur. Systolic or diastolic? Pumption. Systolic or diastolic? Systolic, okay.
one more time.
What?
One more time.
Yeah, okay. Yeah. Pumpa, pumpa, pumpa. Is it orosystolic, mesosystolic, telesystolic? Does it take all the time in the systolic?
The end of the system.
Absolutely, yeah. It's at the end, the boom, the first sound, nothing, and the murmur arrive at the end. Okay, thus it doesn't take all the systole. Indeed, there's a telesystolic murmur, I would say. Okay. The grade, you need the horse to determine the grade. It's not on the audio that you can say it, okay? Stop, it's okay. There's the grade 3 out of 6. It means that it's not irradiating a lot, it's localized, okay? It's soft, and the point of maximal intensity is between the aortic and the mitral valve, okay? You can imagine what will be the next question, okay? What's your opinion for the purchase examination, and what is your diagnosis for this murmur? I will propose you the classical, proposals. If you want to, if the characteristic of the murmur again, it's here. It's okay. Enough time. Let's see. 4 votes. 6. 5. Somebody disappeared. Let's see what we see. Okay. An ejection murmur. It's systolic. It's limited in time. That's why not? Maybe the point of maximal intensity doesn't correspond. But most of you suggested tricuspid insufficiency. The point of maximal intensity is on the left side, between the aortic and mitral valve. Thus, I could hesitate with ejection murmur and a mitral insufficiency. Remember, mitral insufficiency can look like the characteristic, the duration, the kind of murmur. It's very variable. Okay, that could be both, in fact. But tricuspid insufficiency is not possible because this is on the right side. Okay, thus I would exclude it. But indeed, the two first will be possible. Let's see the echocardiography. Oh. Here, do you see something abnormal? No. The first view is completely normal. Nothing special. Okay. I do the M mode, short axis, completely normal also. Okay. We do the tricuspid flow. Oh. Some of you said tricuspid insufficiency. Indeed, if you look at the moment of the closure of the valve, during systole, now you see a very, very small turbulent flow at the closure of the valve. Yes, there is a slight tricuspid insufficiency, but it's not that does the murmur you heard with the stethoscope. Okay? It's because you did a Doppler and you see a very, very small insufficiency, but it's too small to be heard by the stethoscope. This is the tricuspid flow. Oh, excuse me, aortic flow. Okay. Do you see something abnormal? Yes, there is an insufficiency during diastole. No, it's this flow, a little bit turbulent, but again, very small. This is a slight aortic insufficiency. It doesn't correspond to the murmur of the horse because the murmur is systolic, not diastolic. Okay, it's not possible that it is induced the murmur. Okay, we continue, and we have here mitral flow. You see something? Yes, there is a very small insufficiency, but localized also, but attention, because mitral flow is the most difficult to evaluate. Thus, maybe you underestimate a little bit the regurgitant flow, okay? And what is characteristic in this horse is the fact that at the beginning of the systole, the valve flows correctly, but at the end, there is a small prolapse of the valve. I will show that image by image, okay? This is we are here, beginning of the systole. We are before the QRS on the ECG, okay? We progress a little bit, okay? And the QRS is there. I have a beginning of, nothing at this point, nothing at the beginning of the systole, nothing. Oh, there you see a little bit of regurgitant flow. No, the more and more pronounced. And you see here at the end of the systole, you see the regurgitant flow, okay? And it's the most prominent at the end of the systole, okay? And that's it. Okay? And if you look at the valve, okay, more accurately, you see that the valve first closed normally. We are in the systole here, beginning of the systole, and at the end of the systole, here we are nearby the T wave, you see that the valve does a small prolapse in the direction of the left atrium. And this is characteristic of mitral insufficiency, but associated with a prolapse of the valve at the end of the systole. If we do a recording of the regurgitant flow with the continuous Doppler, you see that this is a trace of a regurgitant flow. This is the normal filling of the ventricle. You see the difference between the two traces, okay? You see that it's very high-speed regurgitant flow, and it starts at the mid of the systole, not from the beginning. And it's exactly what we heard with the stethoscope, as a telesystolic murmur. We do measurements of the structure, and for this horse, everything was within normal value. Then in summary, we have a very mild tricuspid and aortic insufficiency and a mild end systolic mitral insufficiency associated with a mitral valve prolapse, okay? And absolutely no repercussion on the heart, functional or morphological. No delayed lesion of anything, okay? Then, what is your attention? Light is up. What's your opinion concerning purchase of this horse, okay? Would it be, it's classical, huh? The same proposal as usual. What would be your opinion? You know the questions now, it's always the same. You can expect the question that will arrive. It's finally the question we have from the owners. Okay, let you a few minutes more. Of course, the best would be to have the theory, study it, and after we do the clinical case, when we just study it. Difficult to remember everything. Okay, favorable for okay, and even you suggest an ECG during exercise. I am not sure it's essential to do the ECG during exercise. It's always a good idea to do it, but not essential. If you see the criteria here, we are all with excellent prognosis in this case. Thus, we are happy to have those guidelines because we can say to the owner, okay, you can buy this horse without any problem, okay? And maybe just do control echocardiography regularly if they want, okay? Thus, we give a favorable opinion in this case, okay? Okay, those cases with prolapse of the valve at the end of the systole of the mitral valve are, in most of the cases, associated with a good prognosis. Okay. Continue? Yeah? Okay, as you want. This one is the stallion standardbred, performing race also, 4 years old. And the clinical history is an exercise intolerance since a few weeks. In fact, it's a horse that was normal during training, but he had problems to finish the races. He is in good position, but at the end of the race, he doesn't win, which is a problem with the racing horse, okay? And the vet that followed the horse had a murmur on auscultation. Physical examination was, as in most of the cases, normal, yeah? And cardiac examination gives this murmur. Systolic. Oh, good. We have only 2 votes. Yeah, take time. Still wait a little bit. Yeah. The point of maximal intensity was on the right side, just right on the right, only on the right, just above the elbow, on the right. Can show you again. Up. Yeah. Let's see what we chose. What you chose. Very uncertain. Okay, it's maximal on the right side and only auscultable on the right side. So automatically, we have only 2 possibilities: tricuspid insufficiency or ventricular septal defect. Okay. In this horse, okay. Now the grade 3 out of 6 for ventricular septal defect, it's a little bit low, maybe. Okay. Now it's holosystolic, that it could be. Okay. And something maybe could suggest a tricuspid insufficiency is the fact that it's a young horse on training. Remember, it's very classical to have a tricuspid insufficiency of those cases. But okay, it will be my differential. The mitral insufficiency, I will not put it in my differential because I am on the right side only. Okay? Let's see. Okay. Lights off. Okay. The quality of the image are not very good, but long axis view is normal. This is the aortic view. I have no septal defects. Okay, but it's important to check. Maybe I will control with the Doppler along of the wall, the interventricular septum. Okay, just to be sure. Short axis view is normal. This is the long axis view from the left side, normal also. Okay, and I do the tricuspid flow, and indeed I have a tricuspid insufficiency, not very severe, but it's there, and that's most likely the origin of the murmur. Okay, you see it? Check. No. Okay, it's the regurgitant flow is here. Not very, very important. Okay. Yeah. Again, in a more general view, do you see it? Okay, a little bit more maybe. Okay. And this one also. Different view of the same thing, tricuspid insufficiency. We do the measurements of all the structures on the horse compared to the normal value for him, and everything is in the normal limit. Okay? Thus, in summary, I have moderate tricuspid insufficiency, nothing else. Okay? It's associated with a murmur grade 3 out of 6 and no repercussion on the heart. What will be your opinion concerning the question of the owner? Is it the reason why this horse doesn't finish the races? Doesn't win? You think that the cardiac abnormality are responsible of this exercise intolerance? Yes, maybe or no? Not a lot of proposals. What's your opinion? See? Maybe. We never know. Okay. It's never a bad answer. I said it already. But I will say a so small tricuspid insufficiency on a horse, a young horse, on training, not associated with anything else, with the grade of the murmur which is very low, the consensus says us that this is a very good prognosis associated with it. But I will be pretty confident in giving a good prognosis on this horse, okay? They remember, evaluate the fact that it can be associated with the training. And in fact, in this horse, we did additional examination and an airway endoscopy during exercise, and he has a dorsal displacement of the soft palate. And in fact, the reason of the exercise intolerance was respiratory and was not cardiac in this case. Okay. Who wants to continue? 1, 2, 3, 4. If you got to go, no problem for me. You can leave when you want, but we can continue with the ones that wants to continue. Yeah? Okay. Case 6. It's a mare, half-blood, 12 years old this time, a show jumper. This is performing very well. The height of the fences she has is very important. 130 centimeters, so very high level of exercise. It's again a pre-process examination. It's a classical case we have, She has very good performance, okay? The buyer tested the horse and the mare is very good. And the objective of the buyer is to buy the horse for his daughter, which is a teenager, okay, 14 years old. She loves horses. She loves this horse, okay? And they want to continue to do jumping, but at the lower level. And they ask you your advice concerning the purchase, of course. Physical general examination, of course, is normal, okay? On cardiac examination, we have this. Systolic, diastolic? Systolic, holosystolic, or limited? Holosystolic. Yeah. Again, it's another systolic murmur. The grade, important. It's 4 out of 6. Okay, it's a little bit rough, harsh. Okay, and point of maximal intensity is over the mitral area. Okay. What's your opinion? And what's your diagnosis? You can imagine the next question. Diagnosis first. Are you ready? Just think about what you will suggest, what we will look at. Okay. And we start with the question. The 4 proposal as usual. You know it by heart now.
It's bilateral or
Not only one side.
only on the left side?
Only on the left side. Okay. Grade 4 on the left side in the mitral area and holosystolic. But we have no more characteristics. Okay. Let's see what's your opinion. Oh, only 3 voted. I will give you a few minutes, a few seconds, just because it became long. Well, exhausted. That's the diagnosis. Okay, mitral insufficiency for all the answering person. I agree. It's the one I will put in first in my list. Okay. Let's see the echo. Opinion? Advice?
The left ventricle, it's rounding.
Yeah, left ventricle shows some signs of overload.
Yeah, and the left atrium is like round.
Yeah, left atrium is rounded also. Yeah, they say put my beam in the. Oh. Let's see. This is the short axis view. Also a little bit overloaded, most likely. Okay. Not good. This is the pulmonary artery. And again, you see that the shape of the pulmonary artery is a little bit unlayered, apparently. The time motion mode is not okay. It's not so exaggerated as the first one we saw, but we have some signs of overload. Let's see the septum, that it's pushed a little bit in the direction of the right ventricle. Now the contraction of the septum and of the free wall is not too exaggerated. There is a moderate signs of volume overload. This is the mitral valve, and indeed, it's mitral insufficiency, a severe one. Okay, you can see it clearly. Okay, this is from the right side. Okay, again, the shape of the left atrium is rounded. Okay, this is the same seen from the left side this time. You see that these are two jets, two resistant jets, one here and another one here. Okay, that's a good mitral insufficiency, severe. This is the recording of the turbulent flow using the continuous Doppler. You see that it's in the direction downwards. That's negative, that's normal. And you see that this time it's holosystolic, as the murmur we heard was holosystolic. You remember the one with the mitral valve prolapse was only at the end. But here it's during all the systole. Okay? We do the measurements and left atrium is a little bit enlarged. Not a lot, but a little bit enlarged. And the ratio between left atrium and aorta is increased. Fractional shortening is a little bit increased also, okay? And the left ventricle is just above the reference value. Not so good. Thus we saw it subjectively, and we can also measure it, okay? And in summary, because this mare is performing completely well, intended for use at a lower level, but she has a moderate to severe holosystolic mitral insufficiency and a moderate left atrium, left ventricular dilation, and some signs of left-sided volume overload. What will be your opinion for this purchase? You have sufficient data to decide. It's classical proposal, as usual. Oh, I have already the answer. I don't know why. From another session, I suppose. I don't know what will be your opinion. You see here the people that answer in the previous session, I think, or SU, I don't know. Well, you are more a little bit doubtful on this case. Huh? Yeah, it's not very good. Okay. Of course, this kind of case is very difficult to say because it can continue to do really good performance for many years, but there is always a risk of evolution. If I could do a control echocardiography in some months to say it will be better, but now the pre-process examination, they want from you an objective advice directly. And you see when look at the criteria of our consensus paper, we have it's shared between fair prognosis to a guarded to poor prognosis. It's doubtful. I will not be confident in this case. Okay, and of course, if they want to continue to use the horse, they have to do an ECG during exercise, just for the safety of the daughter of the future rider. Okay. And control regularly the evolution on ecography. Thus, we give an unfavorable opinion and suggested to do all those things if they select to continue with the horse. Okay. Good. Continue. Some of you wanted to continue. Okay. Some lights, just to wake up a little bit. Yeah. Yes, it's a gelding. It's a Belgian abnormality. It's a crossing between a draft horse and a saddle horse. And when they say they are with the Arabian thoroughbreds, and the name of the breed is Aratel. There are not a lot of horses like this in Belgium, but they are very calm, very kind horses. And this horse was used in a riding school. 14 years old, okay, and he was presented because fever of unknown origin exercise intolerance, tachycardia. Now, this one has a tachycardia, okay, and polypnea since a few weeks. The vets give antibiotic treatment, is a little bit better, and after the problem was recurrent. On physical examination, we had the respiratory rate a little bit high, 28, okay. Some dyspnea, crackles on pulmonary auscultation, and a jugular pulse, bilateral jugular pulse present. Heart rate at rest was 60, okay. The rhythm was regular, but we had 2 murmurs on this horse, an holodiastolic crescendo murmur that was soft. The grade was 4 out of 6, and the point of maximal intensity of this murmur was the aortic area. But we also had an holosystolic murmur, the grade 3 out of 6, also soft, but the point of maximal intensity was in the mitral area, okay? And the owner, it's a riding school horse. He asked you, could I continue to use this horse as a riding at the riding school, okay? And first of all, what is your diagnosis concerning the murmurs? First of all, what do you think concerning the murmurs of this horse? A little bit different this time. Is it a patent ductus arteriosus? We didn't say it together, but it's congenital abnormality, okay? Is it a mitral and an aortic insufficiency? Or is it a ventricular septal defect? What do you think about those murmurs? If you want, I show you the slide with the characteristic of the murmurs again.
Is it a major horse crash?
Is it?
Major horse crash.
Yeah, it's 14 years old. 14 years old one. Okay, Joyce? I will need 2 votes. A more difficult case, maybe. Let you some more time. Yeah, no problem. I hesitate. I was also hesitating with this horse. Let's see what you selected. Okay, all of you suggest mitral and aortic insufficiency. Yes, it was I would have in my head also. Let's see the echo. What do you think? Yeah, left ventricle is clearly rounded. The contraction of the septum is exaggerated. I have signs of volume overload in the left ventricle. Left atrium, it's so big that I don't see it on the screen. Of course, it's a big horse also, difficult to do the echography in such horses, but it's rounded again, okay? Thus I have signs of overload already. This is the view of the aortic road. You recognize? Does the aortic road is here. Left atrium, left ventricle. Do you see something special?
It's not it doesn't move a lot, so that it moves strongly like the movement of the valve.
Okay, the movement of the aortic valve, you mean here?
Yes.
Yeah, it's not clearly the movement, but in the valve you see 2 points of hyper-echogenic points, like if there was masses on the valve. Yeah, the valve is abnormal. Okay, the ventricle contract too much, and we saw it already in the other view. But indeed, here we have a suspicion of a suspect thickening of the aortic valve. It could be just remodeling of the valve with severe degenerative disease of the valves. It can occur in aortic insufficiency. We sometimes do see that, but here it's suspect, okay, and it could be endocarditis, okay. That's again the view of the valve with a strange direction, but we see there is something wrong with this valve. The thickening is a little bit suspect of an endocarditis. Okay. Again, if we stop the view, if you measure those masses, it's 1.8 centimeter. It's a lot for just a valve, you know. There is a suspicion of endocarditis. This is the short axis view. What do you see? Normal. And this is the M mode view here.
Yeah, if you want to click on this.
I can.
Yeah.
Mask it. Yeah, it's easier. Okay, and the M mode view is here. Again, there are signs of overload, evident overload of the left ventricle. You see again this septum pushed in the direction of the right ventricle, and here the contraction of the walls is exaggerated. Okay. This is the pulmonary artery. Again, the shape of the pulmonary artery is a little bit modified, suggestive of pulmonary hypertension. Okay. This is the pulmonary flow. We have a pulmonary insufficiency. Okay. Here. Okay. Well marked. This is the mitral valve. There is severe mitral insufficiency. You see that it takes all the depth of the left atrium, okay? Very severe, very large, okay? Severe mitral insufficiency, going up to in the depth of the left atrium. Yeah?
That's why it's difficult to...
Exercise intolerance? You mean?
Not exactly.
No?
He had volume name.
We will come back to the clinical signs after. Yeah, yeah, we'll come back. There's severe mitral insufficiency, and this is the aorta. Okay, this is the entry of the aorta from the left side. You see also a very severe aortic insufficiency, and remember we had the suspicion of endocarditis on this valve. Okay, and this is the speed of the aortic insufficiency. We do the measurements. We compare two reference value for the horse of the same weight, and you see that he has a very severe dilation of the left ventricle. Let's see. 18 centimeters. The maximum for his weight, body weight, will be 12 centimeters. The left atrium also is very severely enlarged. Okay. And the ratio between left atrium and aorta also, the ratio between pulmonary artery and aorta is increased also. The diameter of the pulmonary artery is a little bit higher than the aorta, completely abnormal. And I have left-sided problem, okay. In summary, the history, 14 years old, she has exercise intolerance, she has fever, okay. Some polypnea, okay, we come back to that, okay. A very severe aortic insufficiency, a very severe mitral insufficiency, a mild tricuspid and pulmonary insufficiency, thus all the valves were insufficient. And we have some nodular thickening of the aortic valve, maybe an endocarditis, that could be in good correlation with the fever since a few weeks. With the polypnea, I will come back to that. It's very often we have that with endocarditis. And we have very severe overload of the left ventricle and the left atrium. Cool. This owner continue to use this horse for as a ridden horse. What is your opinion? Safe? Yes. Yes, but you suggested ECG during exercise. Or you say, it's difficult to say, or you say, is it safe? No, it's not safe. Point at the line. what will be your opinion? You need a summary? He came at the beginning for the respiratory problems and fever. They thought it was a pneumonia or something like that. But when we auscultated the heart, they, whoa, maybe we are not going to do a radiograph of the thorax. Well, let's see your opinion. I think it's quite easy. Oh, some of you say, okay, it could be safe to continue to use the horse for reading school. Can you imagine you have children riding this horse, potentially? You have a big responsibility. It's not you decide, oh, we'll continue to ride my horse. I am an adult. I know the risk and no problem. No, it's for a riding school, okay? It's for sure this horse I will allow to continue. Difficult to say. That's always a good answer. But I think in this case, we can be very, very clear in giving a very unfavorable diagnosis. Let's see the criteria. We have nearly all on the very guarded prognosis. With a diameter of the ventricle, which is so big, a diameter of the left atrium so increased, and the suspicion of endocarditis, prognosis is very, very bad. Okay, and the consensus will be very clear on saying for nobody, even an adult owner shouldn't be stimulated to continue. Okay, does the horse gain at his retirement? He was not used anymore on the school. One more? The ones who want to leave can leave, no problem. Okay, case number 8. It's a thoroughbred mare, 8 years old. Just because she was vaccinated and the vet auscultated her, and he had a murmur on auscultation. But it's a horse that do everything, the 3-day events at a very high level without any problem. What's physical examination is normal, and I don't have the recording, but it's a proto-diastolic murmur with very high pitches, like pum pa pew, something like that. The grade is 2 out of 6, and the point of maximal intensity is in the mitral area. Oh, and he also has a regularly irregular rhythm. The base rhythm is normal, but sometimes there are missing beats every 5 to 8 beats. And the question is, what's your diagnosis for the murmur? What would you suggest? We are in the diastolic murmurs. You have your table, rapid ventricular filling, presystolic aortic insufficiency of pulmonary insufficiency. The characteristics are here. Wait a few seconds. It's nearly finished. Oh, yeah. 4, 5. What do you suggest? You were hesitating between an aortic insufficiency or a rapid ventricular filling. It could be an aortic insufficiency, but the murmur is maximal in the mitral area. The fact that it's in the mitral area, it's very limited in time. It's just proto-diastolic. The pitch of the murmur also. Pum pa pew, pum pa pew. I will put the rapid ventricular filling at first in my diagnosis. This I agree with those ones. On the ECG, we didn't develop the arrhythmias, but on the ECG, we have an idea of what we see. See, indeed, regular rhythm, and sometimes there are some missing beats, and if you look at closely, there are P waves without QRS complex after. This is second degree atrioventricular blocks, but sometimes we have two consecutive of this on the ECG, okay? And the diagnosis, I will pass because we are late now, okay? It's second degree atrioventricular blocks, okay? We do an echocardiography, we have just nothing on echocardiography, okay? And this, on summary, we have suspicion of rapid ventricular filling, okay? And second degree atrioventricular blocks. What's your opinion on this horse? Are you favorable or not favorable to continue exercise with this horse? You remember it was because it was vaccinated that we heard the murmur. What do you say? Do nothing more? Do an ECG during exercise? Difficult to say, or euthanize the horse directly because the prognosis is poor. Will euthanize because you are nearly dead. See your opinion. Okay. Indeed, nothing more to do because all abnormality are physiological. Good answer, I think. No, just we are not going to develop the second degree atrioventricular blocks at this stage. Last case, you want? Yeah. Last case, okay. What is this case? Okay, it's a gelding, okay, our blood again, 11 years old, okay. He has a murmur detected 1 week before, but when he was in colic. Was presenting colic, and it's classic to have a murmur associated with colic, and in a lot of cases, when the colic is resolved, the murmur disappears. Thus, he has no exercise intolerance in this horse, but he has cough and nasal discharge since 2 months, okay, during the winter. That's the history of the horse. Characteristic of the clinical examination is completely normal, okay, and on cardiac examination we have this murmur. Systolic or diastolic? Systolic, am I agree? Orosystolic or limited, but it's written here, okay, that it starts at the middle of the systole. The kid doesn't start directly with the beginning of the systole, okay, and the point of maximal intensity is between the aortic and the mitral area. Well, and the oral said, oh, well, does this horse has a colic 1 week before, but the murmur continue. Soon the colic is resolved, but the murmur is still there. And finally, my horse is coughing since 2 months. Is the murmur associated with this respiratory problem or not? Okay. And first of all, of course, always the same question: what is your differential diagnosis for this horse? What is the most likely diagnosis? And a systolic murmur, you can guess the proposals. Are you ready to answer? I put the question. Oh, but something is going wrong with the question. What do you think? Ejection murmur, mitral insufficiency, tricuspid insufficiency, or a ventricular septal defect? What do you think?
I would go with, mitral insufficiency.
Mitral insufficiency, it's compatible with all the criteria. An ejection murmur, maybe, it's grade 3. It's between the mitral and aortic valve. It's a little bit too low for an ejection murmur, but why not? It's always possible. Tricuspid insufficiency possible? No, we are on the left. Ventricular septal defect? No, we are on the left. It can be bilateral, but only grade 3. It's less likely, and it doesn't take all the systolic. It's not all systolic. This one I will exclude. Okay. This we will keep the 2 ones, the 2 first. Okay. This is the last. Hey, what do we see? A small mitral insufficiency. Yeah. Okay, it's not very severe. You remember the one before? We saw a lot of mitral insufficiencies because it's the problem we see the most frequently. That it's not just by chance that we have that. Okay, to do it short, okay, we do the measurements of the cardiac structure, everything within normal value. Okay. Thus, in summary, my cardiac investigation showed me a mild mitral insufficiency. You saw it was really small, very mild, no repercussion on the heart, absolutely not. Okay, and the owner is with a question: is this abnormality associated with the respiratory problem of this horse? What do you think about that? Do you think yes or do you think no? Are those cardiac abnormality associated with the respiratory problem? Yes or no? Try. You have 50% chance of having the good answer anyway. Just try. No, I think there are some people exhausted. No, yeah, most of you think that indeed a so small mitral insufficiency at this stage. If the horse was exercise intolerant with a so small mitral insufficiency, I will say look at something else. It's not a cardiac problem, okay? And the same for the mitral valve. I have all the criteria to say that the prognosis is very excellent, okay? And I would look for something else. In fact, it was a horse with asthma problem and not with a cardiac problem. Well, a small mitral insufficiency, but that's it. Okay, which is more frequent than the mitral insufficiency. I think at this point you are nearly exhausted. Yeah? And we finished with the cases. Okay. Do we have questions on the, no? You see the variation with one diagnosis, which is mitral insufficiency. You can have a lot of different possibilities. There are repercussion on the heart or not. It can always be possible. Evolution is very difficult to guess, to give an advice on this point, but everything is possible. Okay. Well, I think we can.
The polyplayer cases, it was due to the mitral insufficiency.
Which one?
It had mitral and heart insufficiency.
The draft horse used as a reading school. We are not sure of the endocarditis, but we suspected the endocarditis. We didn't do any complementary tests because we could have done, by instance, a blood analysis to see if he had leukocytosis, if he had SR increase or fibrinogen increase. You could have a look on the protein profiles. I think you did it with Clémence, no? Yes. Such analysis. But it was more cost, in fact. And the owner didn't want to know more than this. It is okay. I know I have my answer. I will retire this horse from the riding school, and that's it. Okay. And he didn't want to have more information, in fact. And with such a dilation, anyway, the prognosis was very bad. I am not sure of the reason, but very, very bad. Okay. Okay.
Então, gente, muito obrigado de novo pela presença de todo mundo. Eu acho que todo mundo conseguiu aproveitar muito bem, principalmente linkando a palestra de ontem com a palestra de hoje. Eu acho que foram duas palestras que se complementaram e todo mundo conseguiu ter uma noção um pouco melhor da parte de cardio, por mais que seja só uma pequena parte de tudo que a gente poderia ter feito. Essa foi a nossa última palestra do semestre. E I want to thank you very much because it was like amazing.
Don't be afraid of your stethoscope. Finally, that's the message.
And thank you for your time. And it was
a pleasure.
Incredible.
And thank you to all the team, because I think that all of you here in the room
participate to the experiments with a lot of energy, engagement. And it was just incredible to see that. Day and night, okay, even with motor holidays, so I don't know what to say for that, but it was just incredible. You are a wonderful team. Continue like this.
Thank you so much.
We'll see the results after.
We have to wait and see.
Yeah.
Mas, gente, muito obrigado. Assim, eu acho que a gente consegue encerrar o ano num nível excelente. Então, muito obrigado para quem assistiu essa e as outras palestras que a gente teve esse semestre. Eu acho que foi um semestre que rendeu bastante. Então, realmente, muito obrigado, gente, pela presença. Boa noite.